Hello and welcome to the second part of this recording of the Optimising Outcomes workshop that Cathy and I presented at AOPA in 2017. In this second part of the workshop, we'll be covering the update on the Rioni, including updated functions as well as training considerations with Cathy. And then we'll also cover mechanical knee considerations. I'll do an overview of the mechanical knee range, we'll introduce the PASO knee, and then cover training considerations as well. So the Rioni 3 has been renamed just the Rioni, and we still have the Rioni XC. And both these knees have new features that we launched at AOPA. They have new optional settings, enhanced stability and stance and swing for lower active users. The optional stance setting provides increased immediate resistance at loading response for increased stability and confidence for users. And the optional swing initiation setting means that the knee will remain stiff and in stance when swing initiation is not activated. When the knee is lifted off the ground at less than 5-degree knee flexion angle, it will remain stable, and this increases the user's feeling of safety, especially when taking small steps in confined spaces. The covers have also been redesigned to be more robust, and there's also a couple of extra features that I'll go into later. In 2014, the Rioni underwent some significant design transformations. The actuator was improved to be stronger, providing more resistance over a wider range of knee motion, to provide more safety and security for users, especially on ramps and uneven ground. The extension assist was enhanced, allowing users to walk faster. A gyroscope was added as well. This allows for backwards walking as well as quiet standing for users. And the battery power was increased, allowing up to around 72 hours of use on a single charge. And it was also structurally reinforced, so the user weight for the Rioni now is 136 kgs. So I'm just going to run through how the Rioni works. We're utilising magnetobryologic technology within a zero pressure actuator. So within the actuator, there are 65 blades that are connected to an axis that rotate against each other. And within the blades sit magnetobryologic fluid. And the magnetobryologic fluid is a smart fluid. When the user puts their weight on the knee, a charge will actually run through the actuator and create the fluid to become more viscous and slows the rotation of the blades down. And this then therefore gives us the resistance in the knee. So the more weight the user puts through the knee, the more charge goes through the actuator and the more resistance that we get from the MR fluid. And you can see from this sort of video in the corner here that as the fluid is dropped onto this magnet, it becomes viscous. But as soon as we turn the magnet off, it will go straight to being fluid again. So we actually get an instant response from stance to swing, where we'll have a high resistance within stance that we require, but then we get a really free natural swing motion as the fluid goes instantly back to being fluid again. And the benefit of this is that we get, not only do we get immediate and proportional responses to gait and loading changes, we also get an easy swing initiation and a natural swing motion because we don't have any hydraulic fluid lag effectively. So with a combination of the magnetobryologic fluid, we also have artificial intelligence in the knee as well. And the way that we program the knee is just by doing an initial setup of only 30 steps. You just require the user to walk 10 steps at a slow speed, 10 at a medium, and 10 at a fast-paced speed. And once you've done this initial setup, it'll have set all the initial parameters for the knee, but it'll also continue to learn after this as well. So there's long-term continuous monitoring. It'll adapt to changes in gait and environment. If the user puts on a heavier shoe, it will dampen the resistances so you don't get thermal impact. And likewise, if you put on a lighter shoe, it'll adjust the resistances to continue a normal and comfortable walking. And the result is that we get an enhanced and efficient walking comfort and efficiency as well. In 2016, the Rioni and the Rioni XC were made weatherproof. So this is weatherproof to an IP34 rating, meaning freshwater splashing from all angles will not have any harmful effect. So users that are in a very humid environment, or if they spill water on themselves, or they splash into a puddle, or want to clean their leg with a hose pipe, that's okay. It's just not submersible, and it doesn't relate to salt water or chlorine as well. So the spring mechanism was again enhanced. So there has been further extension assist enhancements in 2016, providing a faster extension rate, helping to promote heel rise and toe clearance, and enhance the user's perceived safety as well. And the big point here is that it's also helping to lower energy consumption and exertion. The in-house clinical test has shown that users were able to walk further and faster, but feel less exhausted at the same time. The improvement in the extension assist enhancement also assists in the running mode for the Rioni XC. The Rioni XC is offering increased functionality for the more demanding prosthetic user. It's aimed at your K3, K4 users. It features a weatherproof design, but it also has stair ascent capabilities, running capabilities, and automatic cycling recognition as well. So the stair ascent mode requires a more than 25-degree knee flexion angle on loading in order to engage the mode. It'll activate swing extension stop at 25 degrees of flexion, and it prevents hitting the next step and pre-positions the foot for loading. And there are a couple of strategies that you can use for stair ascent. You can teach the user to go prosthetic side first or sound side first. And training is required in order to achieve proficiency with this technique. You'll be focusing at looking at rhythm and timing, the user's posture, ensuring that they're loading the prosthesis adequately, as well as having good hip extension and flexion control. And Cathy will go through some of these techniques later in the presentation. So you can see here from the video that the user is able to initiate the mode and do actually quite a smooth stair ascent. And from here, he's going sound side first of the step. When we did the in-house clinical test, it was found that the stair quality index was improved when using the Rioni XC ascending stairs when compared to their hydraulic microprocessor knee. And they found that it was easier to trigger the stair mode, and that just means that being quicker and easier to learn increases the potential for users to actually use the feature. So the Rioni XC also features automatic cycling recognition, and it now has an improved cycling recognition just using a gyro signal that has a lower threshold. And this just means that cycling is recognized even if the user is going at a slow pace, just helping to improve the usability of the feature. And the cycling mode is just entered by the user doing 2 rotations on the bike with minimal load on the knee. And then they'll receive 1 long beep as a confirmation. And then the knee will move freely with no resistance during cycling. And this will just help to support a wide range of cadence and activity levels and provide an efficient power transfer to the pedals for the user as well. And when the user wants to get out of the cycling mode, they just need to extend the knee to 15 degrees of flexion or less. They'll receive a short beep, and it'll be back to having full resistance again. And just ensure that your user does have the correct saddle height and the pedal height as well, because the knee doesn't want to be fully extending during pedaling, otherwise it will come out of the cycling mode. The Rioni XC has also been designed and tested for intermittent running, typical in activity of everyday life, which is going for a jog after work or in the gym. It does bring the user weight down to 110 kilograms, just bear that in mind for users. And it will activate when the stance time is less than 0.3 seconds. So a user can go from a walk to a run with no mode switching required. During this time, the stair ascent, step over step, is blocked. And the knee's actually been tested up to speeds of 12.6 kilometers an hour. If a user is keen on running and jogging, there are some recommended feet that we compare with the RHEO, including the ProFlex XC Torsion and the ProFlex XC as well. There are some new features to the Rioni and XC that I'll run through now. The covers have been changed on the Rioni and XC to have improved robustness and comfortable kneeling. And there are now the 2 options for enhanced stability control for intercooler users that I briefly mentioned earlier. There's now a more secure and constant swing initiation as well as an easier knee extension from squatting and improved cycling recognition at a slow cadence as well. Ossur now features an interactive functional training module to help the user get the most out of the knee. So just to show you the improvements that have been made on the new covers for the RHEO, the front panel is now being mechanically fastened to the frame, and it features a wider and thicker knee pad to to support kneeling at 45-degree abduction angle. The knee center indicator still remains, and there's now an easier access to the charging port as well as the on and off switch as well. And these have just been designed to improve the robustness of the covers. The Rioni now features enhanced stability control aimed at insecure lower active users. There is an option to adjust loading response to stable, meaning there will be a high level of fixed resistance at loading response as opposed to proportional resistance. And some users may find this more predictable, and it may help increase their feeling of safety. Swing initiation can be adjusted to stable also, and this means that the knee will remain stiff when swing initiation is not triggered, providing consistent support during the stance. The swing is not accidentally triggered, and this can help improve users' feeling of safety, especially if taking steps in a small environment. So both of these settings can potentially be used as a transitional tool while the user is going through early rehab, or used for lower active users who would benefit from the increased security. More active users may find that these settings are less favourable, as they'll lose some of the free swinging dynamics that the Rioni has. The Rioni will provide a fixed amount of resistance at loading response, as opposed to the standard angular velocity dependent resistance when it's set to stable. So the resistance will then ramp up to 50% of maximum, providing immediate high resistance, which is not dependent on proportional load. And this increases support and confidence with minimal load of the prosthesis, and also eliminates any unwanted stance flexion. It will provide increased resistance when yielding down shallow ramps, and it's useful for users that prefer that step 2 gait pattern as well. The dynamic setting is the default Rioni behavior, so you need to go into the app and select stable if you want to use this setting. So in terms of users that you may want to apply this setting to, you could look at primary users that are lacking in confidence, that may require that extra level of security during initial rehab. Users that have got significant comorbidities and would benefit from the increased stability, such as bilateral users. During fundamental weight training and ramp descent training, this function may be useful, especially for less confident users, as well as users with weakness of the core and residuum who have difficulty with getting the required loading on the dynamic setting. Other applications for users negotiating uneven ground and surface transitions. For instance, walking onto concrete to grass. When the grass is softer, they'll still notice the increased resistance at loading response. So just to explain the enhanced stability control for swing initiation, if it's set to stable, the Rioni will prevent swing flexion outside of typical ambulation pattern. So when the prosthesis is lifted off the ground with less than 5 degrees of flexion, the knee remains in stance. So it'll be stiff. And this is ideally useful for lower active users who prefer a stiff leg ambulation pattern when taking small steps, for instance in a confined space such as the kitchen and the bathroom. The stance to swing will not be triggered accidentally. For instance, if you're turning with the RHEO on an inside step, the user will actually need to do a good heel and roll over to initiate swing. And again, this setting is something that you can consider using for insecure users during initial fitting and early rehab. So with these videos here, we've got the dynamic setting on the left and the stable setting on the right. In this case, I asked the user to walk around in a confined space and pick up objects and take in small steps. And you can see with the dynamic setting, the knee is bending and swing is being initiated on most steps. Whereas with the swing initiation set to stable, you can see that the knee is mostly remaining stiff and staying in stance, which the user in this instance preferred for the feeling of safety and stability. There have been some other improvements on the Rioni and the Rioni XC. They've improved and made a more consistent detection of swing initiation by adding shank rotation range as a prerequisite to transitioning from pre-swing. They've also provided more consistent support during stance as swing is not triggered accidentally. The knee is now easier to extend from in a squat position. It detects extension from a high flexion angle, and it then lowers the extension damping value to make it easier for the user, and it allows more contribution to the prosthetic side, helping to save the sound side when extending from the squat. And as I've mentioned, they've improved this automatic cycling recognition to be recognised at a lower threshold. It just means that cycling is recognised even at a slow cadence as well. It just helps to improve its usability. Rioni users can download the Ossur Logic app from the App Store and access the user mode for free. They're unable to change anything specific to the knee other than the extension hold, which they can turn on or off, but they can access their step count, their charging status, and their battery status as well. So I'm just going to hand you over to Cathy, who's going to go through functional training for the Rioni and the Rioni XC.
Thanks, Sarah. We're going to look at the benefits of the Rioni and Rioni XC with the weight-activated stability and including now the enhanced stability control. The knee accommodates to changes in walking velocity. It has smooth transitions between the phases of gait, and it has the potential, when used with the ProFlex and training, to decrease stresses on the remaining limb, a very important consideration for our amputee clients. Previously, the Rioni was just a weight-activated system, where the stance resistance responds proportionally to load, and the body posture can influence the response. So the client had to load the knee aggressively to get a significant amount of resistance and feel confident in the knee. Now, however, we can switch on the enhanced stability control, which provides a consistent resistance at the loading response, a more consistent swing initiation, adding security, and the knee is remaining stiff if swing is not triggered. Other improvements include an easier knee extension from the squatting position, also rising out of a chair, getting off the toilet, things like that are going to be easier, and an improved automatic cycling recognition at slow cadence, obviously only with the XC. The application for the enhanced stability control will be as a transitional setting for the primary user who is unable to load the prosthesis aggressively initially because it's not comfortable for the stump and you need to increase the amount of weight accepted by the stump slowly. So by switching on this setting, they'll get more response from the amount of load that they are able to put onto the prosthesis. Older or less stable amputees requiring an increased feeling of safety. The one that excites me the most, I think, is the group with significant comorbidities. So these will be our K2 classified amputees who have the potential to become a K3 level amputee if they were given the appropriate componentry, such as the RHEO. And these patients will include those with ipsilateral upper limb involvement, so a lot of your motorcycle vehicle accident victims, for example, who have the amputation on the side and the ipsilateral side with brachial plexus involvement, so they are unable to put weight through the arm on the same side as the prosthesis. Bilateral amputees and those with neurological conditions such as head injury or stroke will now get more bounce to the ounce really out of their RHEO knee joint for less load putting on the prosthesis, and that can be very valuable for these types of amputees. And amputees with weakness of the core and residuum who have difficulty with required loading on the dynamic setting. All of these people will now be able to utilise the RHEO with the enhanced stability control function. We're looking at gait now with the RHEO. Gait will be optimised by reaching full toe off and end of range hip extension. The full toe length lever results in a longer stance phase on the prosthesis, which initiates the extension moment at the knee, resulting in a smoother transition from stance to swing phase. Combined with a flex foot, there's a smoother transition onto the intact leg. So by staying on the prosthesis longer and getting right to the end of the toe, the weight can be placed from the prosthesis onto the sound limb more gently, decreasing the stresses on the remaining limb. This results in a more symmetrical gait, and it's also essential to achieve this end of toe off position to initiate swing when your enhanced stability control is activated. remembering if you don't achieve that, the knee will remain stiff. Amputation affects core stability of the transfemoral amputee by decreasing the ability to stabilise the pelvis during prosthetic stance phase in the anteroposterior plane. And it happens like this. As we see on the right-hand side, in the case of the transfemoral amputee, with sectioning of the hamstrings, there is an anterior tilt of the pelvis, remembering that the primary function of the hamstrings is to stabilise the pelvis during stance phase by activity. So by sectioning these muscles, we have an increase in the anterior pelvic tilt during stance. With that positioning comes the increased activity of the rectus femoris and iliopsoas muscle on the anterior side of the hip joint. These muscles become shortened and overactive, and because of the constant anterior pelvic tilt, we may get tightening of the muscle, overactivity of the muscle. On the opposite side of the pelvis, we then have hyperextension of the lumbar spine, which leads to shortening of the erector spinae muscles. And of course, opposing them is a longer, weakened abdominal muscle. So we get this situation where it can be quite challenging for the transfemoral amputee to control this increased predisposition, if you like, to anterior pelvic tilting during prosthetic stance phase. Now on this slide, I've just summarised all of that on the left side of the slide. On the right hand of the slide, I've written down the consequences of this for transfemoral gait. So if those circumstances arise and there is an increase in anterior pelvic tilt in the sagittal plane, there will be a decreased push-off by the hip extensors, a shortened intact leg step length, difficulty initiating and clearing the prosthesis during swing phase. And this may lead to shortening of the prosthesis, which predisposes to other gait deviations such as lateral trunk bending and so on. And it also leads to impaired momentum and loss of power for the transfemoral amputee. Other pelvic movements during gait that reflect a decrease in core stability are an increase in pelvic rotation in the transverse plane on the prosthetic side at the end of stance phase. This indicates a weakened end of prosthetic stance with decreased push-off from the prosthetic toe. So you won't be getting right onto the end of your toe. You won't be getting the value out of your proflex or your strong toe lever on the prosthetic side. It may be associated with external rotation of the foot, and the avoidance of the toe lever means there'll be impaired momentum. And of course, remembering if you're using the enhanced stability control of the RHEO, you won't be getting initiating of swing phase of the prosthesis. This video shows exactly all of that, pretty much less words. And you can see that the shortened stride with the sound limb means a shortened toe lever. Swing phase is initiated early, prior to toe off of the prosthesis, means that there's actual difficulty initiating the swing and catching of the prosthetic foot. And this is often when your clients will say, my prosthesis is too long, can you shorten it? We would recommend not shortening the prosthesis, but actually training the client to the correct length of prosthesis, because shortening the prosthesis prematurely is going to lead to back pain and things like that for the transfemoral amputee. So to enable a full range of hip extension, we need to prevent hip flexor complications during the amputee gait. So we need to pay a lot of attention to hip flexor stretches, as seen here in the picture on the left. This is an advanced stretch for someone who's wearing their prosthesis, and they can do it at the end of their training session or the end of their day. It's stretching the hip flexors with associated core activation and prevention of pelvic rotation anteriorly and incorporation into the amputee gait. Adequate hip range of movement and strength available through the range can be done by simple exercises on the bed. So for people undergoing the early phases of rehab, lying prone with something underneath the stump, as you can see on the left-hand side, and just relaxing the hip into extension daily for 20 minutes at a time. And then we can superimpose on that extension exercises while pushing the anterior superior iliac spine on the same side down into the bed, which means we're activating the core at the same time as the hip extensors. We do not allow the pelvis to come off the bed. On the right-hand side, we can see the strengthening of the extensors using TheraBand when the prosthesis is donned, and the hands are indicating their co-contraction of the abdominals at the same time to prevent hyperextension of the lumbar spine. To gain confidence in weight-activated resistance of the RHEO, we do a simple testing exercise of the knee in initial training so that the client feels as they load the knee, there's that increased response and increased resistance of the RHEO so that they won't be frightened of weight bearing on a flexing knee joint. During the training on the RHEO, we'll be strengthening the core and hip muscles on the loaded RHEO, paying particular attention here on the right-hand side to where the weight is taken through the prosthetic foot. And it should always be directed down through the heel so that the RHEO is not permitted to move forwards during space and reach the toe and then accidentally triggering a swing phase. So we can see that idea here in the video of gaining effective weight bearing through the prosthetic side, getting lateral pelvic shift so that he's bearing weight effectively, has shifted the pelvis across onto the prosthesis, and controlling the location of weight bearing along the length of foot. You may have noticed when the weight went towards the toe, the RHEO started to flex. When the weight's taken down through the prosthesis and through the heel, you've got full stability on the loaded RHEO there. And this is a very good transition into the gym for our K3, K4 level amputees who are starting to use resisted exercise on soft knees or knees in slight amount of flexion. The RHEO provides a great amount of stability during stance phase or stance resistance activities, such as sitting and squatting. And so I spend a lot of time with the clients practicing sitting and squatting drills. Emphasis again is on weight bearing through the heel of the prosthesis. And here the core stability and gluteal activation are important to maintain a neutral lumbar spine and pelvic position, thus ensuring that the prosthetic knee does not translate forward in space. So we're training people here to actually lift safely so that their lumbar spines won't be compromised and they can do things like unload the boot of the car or lift children off the floor, things like that. As we saw in the first presentation, resisted drills and resisted exercise is very important for achieving that lateral pelvic shift. And of course, lateral pelvic shift is essential for effective weight bearing on the prosthesis. So we can see a drill here, which is resisting the lateral pelvic shift to increase the pushing down and backwards through the prosthesis. And then on the right-hand side, resisted backwards walking, emphasising pushing into the RHEO during stance phase resistance. I teach stair descent first when dealing with stairs, and although you can see him placing just the heel on the step, if you combine the RHEO with the ProFlex, the user will be able to leave more of the foot on the step during step descent, which is very reassuring for the client. A lot of people like to do that. Notice that the rail is on the same side as the prosthesis as he comes down. Again, this is to encourage shift of the pelvis onto the prosthetic side and encourage weight bearing on the prosthesis so that he gets maximal stance phase resistance as he puts the weight on the flexing RHEO to descend the stairs. To progress up the step, we need to trigger the knee into step mode, and I find the easiest way is to start with the sound limb already on the first step. You can then trigger steroscent mode by a quick extension of the hip followed by a quick flexion of the hip. So this breaks the knee, it swings up to dangle over the step. You can then place the foot on the step. We then need to load the RHEO, not letting the knee translate forward in space. So again, weight must come down through the heel, the knee stays still, and the patient then pushes down and back with the stump into the socket, thus extending the knee, and they're able to step up onto the step above that. It's much easier to continue once you're in the rhythm of going upstairs. Once you get to the top of your steps, if you're finishing with the prosthetic foot first, you need to extend the residual limb, roll over the prosthetic foot, and take a small step with the sound side and continue walking. If you finish with the sound limb first, the RHEO won't realise that you've finished the steps. So you need to pause for a split of a second, let the knee straighten, and then continue walking so that the RHEO knows it's not on a staircase anymore and you're going to continue off with flat surface walking. Training on slopes, tips for that are you can now use the enhanced stability mode so that when the patient is a little reticent in loading the prosthesis, they'll get more response, more loading response and more resistance so that they can increase their confidence in coming down the slope. Avoid overstepping. So we don't want large prosthetic step lengths because this will then encourage hyperextension of the stump and fighting at the knee joint and not letting the knee go through its flexion phase during prosthetic stance as you descend. The bottom video there shows you descent of the slope with the ESC mode or Enhanced Stability Control mode switched on. And you can see there's quite a large amount of resistance and the stance phase is quite slow as this gentleman descends the slope. It's a really good confidence booster. You can then back that off in the more advanced case, which is the top video, and the knee will then flex quicker and they can walk down the slope more quickly. We need to maintain an erect trunk so that the weight falls behind the knee joint. And really, I just give them the direction of riding the prosthesis down. There's no need to have really any stump activity at all. If they're having trouble letting it go, I will encourage them to push forward into knee flexion as they come down the slope.
Thank you, Cathy. So just to kind of build on what Cathy's just talked about in terms of functional training for users with the Rioni, the company is actually developing an app to make functional training more accessible for users. So this will be available in the Ossur app, and it aims to help develop fundamental skills for mobility progression with the RHEO, increase users' confidence, and it'll also be available via the user app, so users will be able to do this at home. And it will include training instructions, videos, as well as visual and audio feedback on the execution of the exercise. And this is still in development, so we'll be going and working with you with this on a one-by-one basis when we go and do RHEO trials with you and in visits, just to help you use the app and get your input whilst it's in development. I'm just going to run through some of the clinical outcomes from the study with the Rioni XC. The users in this study consisted of 13 unilateral transfemoral users. There was 3 previous Rioni 2 users, original Rioni 3 users, as well as some hydraulic mind compressors in the users as well, including 2 people on a GM, an X3, and a C-leg 4 as well. And what they did was they took a series of outcome measures and then compared it to Rioni XC after 3 weeks of use. And it was found that there was an 18% increase in the distance walk during a 6-minute walk test. And at the same time, a 36% reduction in energy exerted in the Borg scale, indicating that users were able to walk further, but with less energy exerted at the same time. And there was also a reduction up to 9% in the L test as well. So the 6-minute walk test was performed by each participant, and as I mentioned, this was a significant difference of 18%. And the results to this can be attributed to the nature of the RHEO actuator technology, as well as the faster swing extension than in the previous models. And one of the interesting things that came out of the 6-minute walk test was that the K4 users in the study actually stepped up into the performance level that's actually required if you're going to go and become an active duty soldier in the US Army with a transfemoral amputation. So the users were able to walk very far in this 6-minute walk test with the Rioni. And then again, alongside this, then the Borg scale, which is a self-reported scale of exertion, was found that there was an improvement of 36% in this as well. So users were saying that they could walk further, but they were reporting to be less exhausted at the same time. The L test consists of ambulation over 20 meters and includes 2 transfers and 4 turns. And it's a timed event from when the user rises from the chair to returning to a seated position, walking at a self-selected speed. There was improvement in the L test, which is used to indicate falls risk. It consists of ambulation over 20 meters and includes 2 transfers and 4 turns. And it's a timed event from when the user rises from the chair to returning to a seated position, walking at a self-selected speed. And although this is a very simple outcome measure, again, it's related to falls risk, and there was a 9% reduction in this. The PEQ-MS was also reported to provide significant differences in the person's quality of life when they compared the Rioni XC to their previous prosthesis. And we have developed a reimbursement support tool for the Rioni and the Rioni XC. Within the document, we've outlined mobility, health, and lifestyle benefits for using the RHEO, complete with references to help with written applications for funding approval. Recommended treatment pathways and product features and benefits are also listed, as well as customer and client testimonials. And this copy is available on our website for you to download, or please get in touch with me and I can email you a copy as well. We're actually intending to develop further reimbursement support tools for a wider range of our products in the future also. So this slide's just showing you the complete set of knees that we've incorporated into our range. We now have knees ranging from K1 to K4 and a mixture of pneumatic, extension spring, friction brake knees, as well as hydraulic knees as well. The locking knees is a very simple, lightweight, robust single-axis knee. We have a balanced knee IFM2, which is a friction brake knee, which is great for you K1, K2 users. It has an optional lock just to provide the extra stability in early rehab. For users that can vary their cadence, there's the OP2, which is a full bar knee. It's going to give the user some swing phase shortening, as well as the pneumatic cylinder to allow K2, K3 users to vary their walking speed. The PASO Knee, I'll talk about in more detail in this presentation. It's a really exciting new knee with an auto-adaptive pneumatic swing phase control, which allows the user to go from very slow to very fast-paced walking without any requirement to adjust the valves. And if you're interested in learning more about the mechanical knees, there is a webinar that purely focuses on them, including the features and benefits, the applications for use, and the adjustments that you can make to them. And you can find that on the website under the webinar section on the Ossur Australia website. Otherwise, we also have a mechanical knee prescription guideline that we've developed, which is also available to download from the website. And this covers the full range of knees as well as the indications for use. And it also combines foot pairings as well, so you can look through that and get a complete solution for your transfemoral users. I'm going to discuss closing geometry, which some of the knees in the range have. Closing geometry is different to standard closed-centric geometry, where the instantaneous centre of rotation is positioned posterior and proximal at heel strike. The knee will bend and the patient will then initiate a hip flexion moment in order to do so, whereas with closing geometry design, instantaneous centre of rotation stays behind the ground reaction force for a greater period of time, and this creates enhanced stability. With the closing geometry at initial contact, the instantaneous centre of rotation is in front and below the ground reaction force, which you can see here. And this means that the knee is inherently stable even if the user creates a hip flexion moment at this point. At mid-stance, the instantaneous centre of rotation moves through the floor until the front and the rear bars of the knee move into a parallel position. The instantaneous centre of rotation then moves to proximal and posterior at terminal stance, and the ground reaction force is therefore still anterior to the instantaneous rotation until the toe is loaded and a hip flexion moment is initiated. So just to break this down into 3 sections, just to make it easier to digest, at initial contact, the instantaneous centre of rotation is in front and below the ground reaction force. Loading the knee at heel contact will push the knee into extension, increasing safety at heel contact, even on uneven ground, and this provides a higher level of safety and stability for the user. During mid-stance, the instantaneous centre of rotation moves through the floor due to the design of the knee axis, and then the front and the rear bars of the knee move into a parallel position, and the instantaneous centre of rotation then moves to be proximal and posterior. And once the toe is loaded and a hip flexion moment has been initiated, the ground reaction force will move posterior to the instantaneous centre of rotation. The knee will then flex, and the user will be able to initiate swing phase. And the level of safety that the closing geometry of the knee provides is comparable with the geometric lock that the total knee range provides. And it's also worth noting that this safety element only works when there are no wedges used in the knee. So there are the OHP3, the OH5, the OH7, and the PASO that all contain this feature, just to give the user a higher level of stability during stance. So now I'd like to discuss the PASO with you. If you can see the video in the corner of the screen there, the PASO is actually named after a Peruvian breed of show horse, as it's known for its smooth ride and ability to take small, quick steps. So that's where the name comes from. And the knee is pretty exciting, and it's something different to the market as it features an auto-adaptive pneumatic swing phase control, which requires no valve adjustment and therefore can be used straight out of the box. The knee is indicated to be a transfemoral or through knee users. It's actually suitable for a wide range of users from K2 to K4 due to its high level of stability and stance from the closing geometry, as well as the ability for varied cadence and faster paced walking for more active users. And the knee adapts incredibly well to changes in walking speed, and it's also capable of smooth and powerful running as well. So with the PASO, we can guarantee speeds of 7 kilometers an hour, however it can go as high as 12. And wedges can also be applied to adjust the geometry and make it more dynamic if it's required for more active users. And there's also a choice between full proximal adapters, including a stance flexion adapter if that's preferred for a user as well. So just to run through this video so you can see how it works. The PASO consists of one large chamber and a piston, and a smaller chamber at the bottom with a spring-loaded outlet, which is capable of closing to create turbulence to allow for varying resistances for flexion and extension. So when the user is walking at 2 kilometers an hour, the small chamber outlet remains open, and this allows air to flow out of the chamber. But at faster walking speeds, up to 7, this small extra outlet in the chamber closes. And when it closes, it leads to a buildup of higher pressure and more turbulence within the chamber. And this effectively dampens knee flexion. It limits excessive heel rise, but it also promotes extension by pushing the piston faster into extension to keep up with the user's faster gait speed. And before the knee reaches full extension, there's a buildup of pressure above the piston, which prevents a hard bump at terminal impact. So the cylinder is therefore auto-adaptive, and there's no requirement for any adjustments to the pneumatics, hence it can be used straight out of the box. And in this video, you can see that the user is walking at a very slow speed, actually less than 1 kilometer an hour, 0.8. However, he's still able to swing through at a suitable rate to match his sound side, displaying even step lengths. And as we move on to his faster walking speed, he's now walking at 3 kilometers an hour, and it's gradually going to be increased to 4.5 kilometers an hour. And the knee is adapting and keeping up with the change in walking speed. Heel rise is even, and there's no terminal impact present. And most pneumatic knees are generally limited to speeds of around 4 kilometers an hour. And in this video, you can see the speed's been increased and the user is building up to walking to around 7 kilometers an hour. Users will start to jog normally at around 6.5 kilometers an hour. So he's gone from a slow walk of 0.8 kilometers an hour, and he finishes up here at a speed of 6.8 kilometers an hour without showing signs of uneven heel rise and terminal impact. And one of the benefits of pneumatic swing phase control over hydraulic swing is that it can provide a more energy efficient gait for the user as long as it can keep up with the user's pace. So in this instance, we have a knee that can cope with very slow to very fast-paced walking and is also capable of running. And I have this clip here that I can show you of a user who's able to run at 12 kilometers an hour on a treadmill, and the knee is able to keep up with him. And here we've just got an example of Gordon walking on the PASO as well as running on it. He's utilising the Proflex on the left and the Proflex XV torsion on the right. You can see smooth gait, adapting to his speed, but also enabling him to run as well. And there's several feet that you can choose from with this knee, as it covers a wide range of cadences and activity levels. Anything from the Veriflex to the Proflex XC range, the Reflex Rotate and the Reflex Shock as well for your more active users who are looking to run as well. I'm just going to hand you over to Cathy, who's just going to discuss training considerations for users with mechanical knees.
Thanks, Sarah. I thought I'd take this opportunity while we're talking about mechanical knees to really address the problems in early rehabilitation, because getting it right early on is essential for building confidence in the amputee, and then they're using their componentry to more advantage. And the first thing that needs to be trained is that safety is all to do with where they put their foot of the prosthesis, and the safest place for your prosthesis is underneath you. So if we can see the picture on the left, a commonly adopted posture which we really need to avoid, in that the amputees place the foot anteriorly to the other foot, creating an unstable knee and a flexed hip, whereas on the right-hand side we can see correct posture with the prosthesis underneath the patient. The knee is in its best position of stability, the hip is extended, and we can reinforce the correct foot placement, which is underneath the hip, not out in front. In initial gait training using a mechanical knee joint, we need to train hip extension and core stability at the same time. We need to have the erect trunk and the hip extending underneath the amputee as they step forward with their sound limb. On the right-hand side, we can see a progression of the exercise with resistance being applied laterally to the prosthesis, thus increasing lateral pelvic shift and effective weight bearing through the prosthesis, making them extend the hip more strongly and thus creating a very stable knee joint to walk over. How aids are used in initial walking has a big influence on amputee gait. So if the sticks are placed too far forward, as in this picture, you will see that trunk flexion and hip flexion on the prosthetic side is encouraged. This means that the hip on the prosthetic side is low and posteriorly situated. The prosthesis then is functionally lengthened, so we're going to have difficulty in breaking the knee for prosthetic swing phase. You're going to have problems with toe clearance, and the patient will want prosthesis shortened. And you can see that he's going to come off that prosthetic foot in that photo at about the midfoot level, not actually onto the toe. Whereas if we contrast it with this slide, when the sticks are actually placed in the correct position, you can see that the trunk is erect, the hip on the prosthetic side is erect, and the weight can be transferred onto the front of the foot by extension of the hip on the prosthetic side. Mechanical advantage is achieved to break the knee easily for swing phase. There's high positioning of the hip, which facilitates toe clearance during swing without the need to shorten the prosthesis. And you can also notice that the step length with his sound limb has been increased. So we can move towards equal step lengths. Falls and lack of confidence in the knee joint will occur, especially in the turning situation, changing direction, approaching a chair to sit down, or turning around to sit on the toilet. If the prosthesis is used as a strut and not a leg, the clients will tend to swivel around on the heel of the prosthetic foot and then not step around completely. They'll just put the prosthesis out, try and swivel on it, and swing their bottom around onto the seat. So the prosthesis is placed in a position where the alignment is unsafe. They'll load their prosthesis and the knee joint will be forced into flexion. There'll also be excessive rotation forces around the stump in this sort of situation. If we contrast this to the picture on this slide where the prosthesis is kept underneath the line of the hip, the weight is going through the heel of the prosthesis and he's turned around to be totally in line with the chair, the inherent alignment of the stability of the prosthesis is maximised. We need to have constant reminders for clients to do this because initially they won't want to do it. They need to step around, never spin on the prosthesis. The prosthetic foot should always be kept under the hip on that side with the prosthesis loaded for maximal stability. If we look at going down slopes with mechanical knee joints, we can do this without sideways walking. If you want a completely safe way of going down slopes, you can do it sideways. However, if you want to walk down the slope front on, we need to take small steps. Emphasis is on strong hip extension on the prosthetic side, and a step to gait is performed only, not a step through gait. So you step forward with the prosthesis, step up to the level of the prosthesis with the sound limb, and then step forward with the prosthesis again. Note in the picture on the right-hand side that the toes never meet the step, and the knee joint is being maintained in extension by strong hip extensor activity. So if we have a look at this on the video, you can see as Gordon descends the slope, the toes never actually reach the slope. He keeps the weight back on the heel of the foot and steps to the level of the prosthesis, not through the prosthesis, because that would then force the knee into flexion, and that's called jackknifing, as you can see on the right-hand side. So if you step through on the right-hand side video, as Gordon does, you'll see the jackknifing as the knee collapses into flexion. And of course, walking up is unaffected. With negotiating stairs, one step at a time, obviously, upwards with a mechanical knee joint. And coming down, we are placing the prosthesis first, entire foot on the step, and then stepping down onto the same step with the sound leg. If you've got someone who's a little bit more active and doesn't have a weak heart, and you don't have a weak heart training them, you can teach the jackknife technique, as you can see on the right-hand side, where the foot's hung a little over the step and they step down onto the step with the sound limb below them and the knee collapses underneath them with the jackknife action. Running with the PASO knee, first of all, I always go to the hop-skip method of running, just because it's an easier option than leg over leg running. It's an easier transition onto the prosthesis. There's not that 3 to 5 times of body weight that's going to go through the stump when you fly onto the foot in prosthetic stance during prosthetic running. Hop-skip method means there's a double hop on the sound limb side, which allows time for the prosthesis to swing through, and then a single phase, obviously, on the prosthesis. So double on the sound side, single on the prosthetic side. And then you can move on to leg over leg running with the PASO, as we saw on the video on the treadmill, and you can see here in the hallway, with no excessive extension or no excessive heel rise of the prosthetic foot and no excessive terminal impact. And there's no adjustment necessary to do that. It just happens intuitively with the PASO. We don't recommend going straight on to running with any of our clients. There is a definite strengthening and preparation phase for the body that's required prior to amputee running. And this is to avoid injury to the stump and injury to the lumbar spine. Remembering those increased forces that go through the prosthesis and then further up the body are 3 to 5 times body weight during amputee running. So we need significant strengthening of the core, stability of the hips, and maintenance of spinal alignment during the prosthetic stance phase. And this is just one example of such an exercise that we might do. If you actually want to learn more about the nuts and bolts of teaching your clients to run with a prosthesis, I'd recommend highly coming to one of our Ossur mobility clinics, Australia and New Zealand. And we can reveal the next one will be held in Adelaide in 2018. They're not only for running, but they're for incorporating sport into the lifestyle of your amputees and just generally improving mobility. And I hope to see you there with all of your clients wanting to get more out of their prosthetics, and you can meet our inspiring bunch of Ossur champions and coaches at those clinics. See you there.
Thank you, Cathy, and thanks everyone for listening. If you have any questions about any of the content in this presentation or the Part 1 presentation, then please just try and find our email addresses on the website and contact Cathy or myself, and we'll be more than happy to help. Thank you very much. Bye-bye.